welcome back. I'm Mabel Jong, and Ian Laird is here. He is National VP of Growth at DaVita Health Solutions. Thank you.
Nice to be here.
Thank you so
very
much. Thank you. And as a new attendee here, you got a chance to look at the top 10 list put together by the HCEG membership. Did you find any of those being especially applicable to what you do at DaVita?
Yeah, I mean, there's three that really stand out to me. The first would be value-based care. It's a personal sort of passion of mine, but that one, really shifting the entire system from a volume-driven model to a value-driven model, I think is critical for the U.S. healthcare system. It's applicable to us at DaVita Health Solutions because that's actually the only way we contract. Right, the way we work is we do in-home primary care for high-risk polychronic patients, and we take full risk on that. So that's really our preferred method of contracting, and we believe it's the right way to align all the incentives and ultimately get to the right outcome for the patient.
And do you find that the environment is changing in this area? And is it getting more supportive of the work that you do, or are you finding it more challenging?
Yeah, it is shifting in our direction, right? It is becoming more supportive in a couple ways. So you see things like CMS pushing for more downside risk and really, pushing the provider community to take full accountability for the cost of care as well as the quality of care, which I think you're seeing the commercial payers do the same thing. That's where the industry is going. It's scary. And one of the things that's coming out of that, and one of the things we firmly believe, is that as part of that, you really need to have a differentiated model of care. You can't sort of have everybody treated the same way. You're seeing CMS change some of the regulations around that, et cetera. But for example, we focus on that top 5% risk patient, but they represent 40 to 50% of the total cost, right? So investing more in having a differentiated model of care for those patients really pays dividends for the whole. And it's, if you're a primary care physician, sort of a community primary care physician, you are absolutely clinically capable of taking care of all these patients. You know clinically what to do, but the problem is that you're organized around a 7 to 10 minute office visit, right? That's just the way your business is structured, the way your operations are structured, and this is 5% of your, if you've got a panel of say 2,500, patients, I think it's unfair to ask them to have a completely different business model or organizational, operational model for 2 patients a week. Right. So what we'll do is we'll take all of those patients from all the community PCPs. We will work with the PCP. We don't steal the relationship. We want that relationship. But then we organize our medical group specifically around the needs of a high-risk population. So our business organizational operational model is centered around that very high-risk patient. So the one who needs a half an hour, who needs an hour, we're prepared for that. We're not trying to then jam it into a smaller visit. It's just, you can't live in a foot in 2 canoes, right? It's just not fair to ask them to do that.
Okay. So given that, do you find that there might be more sort of subsets of what you're working on to address the needs of those patients that don't fit into that model?
Yeah, I think you're seeing that across the industry, right? People who are taking accountability, again, usually in a value-based way for a specific type of patient, right? You see this, I think Thrive is doing this with opioid addiction, right? And we're doing it with high-risk polychronics, and so you're seeing others do it with behavioral health. So there are people who are saying, I've got a model that's appropriate for a specific segment of the population. Let me deliver that model of care to that population, and I'll take accountability for and making sure there's an ROI for the payer.
Okay. What other sort of information are you getting from the sessions during your time here that you found especially valuable?
I'll call it kind of 3, right? So to hit back to the theme I was talking about, these subpopulations and whatnot, right? That's the, I think it's number 4 on the list, is the population health, right? So that's sort of top 10, and that's the chronic care management that we do. That's the behavioral health stuff that others are doing. So I think that's one of the things that it ties into. But in the sessions, some things I found particularly interesting, the great conversation around transportation was great. How do you remove the barriers of access to care, right? And so good discussion about how do you bring the patient to the care, right, and alleviate transportation. We also touched a little bit about how do you bring the care to the patient, right? And that's, we do that with the in-home primary care. Others are doing it in other ways, through digital technology or whatnot, but it's removing that barrier to access. The other one that stuck out to me was the session this morning about how, utilization management is happening. It's effective through, again, taking some of these subpopulations and taking accountability for them. But there's still a need in the industry to address the unit cost issue.
Okay.
And that's an ongoing thing. That got my mind thinking, right, about different ways of looking at it. And I have a payer background. I sort of come from the payer space, so that really got my engine going in terms of intellectually how do we need to think about things a little bit differently.
Is there anything that you think should be on that list that perhaps isn't there, or should be higher on the list?
I would. I'd actually call out two things, right? I think we've talked about it so far a little bit, but I would spike them out, which is that how do you take a differentiated model of care for particular populations, right? Not everybody is created equal. Different populations have different needs, and what are the right stratifications of those needs? And then, just the whole trend in home, right? A lot of people are trying to do things in home, be it, hospital in home, urgent care in home, primary care in home, home care, right? There's a whole trend in home that I think is worth exploring. I think that's a big theme that we're seeing in the industry.
Okay, great. Is there anything that you want to add, Ian, that might be of value to members here?
Yeah, I think the only other thing I would add, I think there's a big discussion about digital and data and the analytics, which I think is absolutely key and important to the industry, especially around predictive analytics. How do you get in front of, not looking retrospectively at, say, who had a condition that was expensive last year, but who's going to be expensive next year? Because what we're really talking about is how do you apply the right clinical resources to the right people to maximize outcome? And just looking backwards is harder. You need to be starting to look more forwards about who's going to have episodes of care, especially around their chronic conditions, and really do that sort of predictive modeling so that we can be ahead of that cost curve.
All right. Ian, thank you so much for your time.
Thank you. I really
appreciate
appreciate it.